Hi, everyone. I'm Dellann Elliott Mydland, President and CEO of the End Brain Cancer Initiative. And our mission is to help patients with disease in the brain, with cancer in the brain and the central nervous system to receive the best care possible and to educate them about the necessities of considering a clinical trial and advanced diagnostics as part of their treatment options. And today I have the pleasure of getting to spend some time with Dr. Christian Grommes. He is a specialist in the disease known as PCNSL. And I want to tell you a little bit about him before he gets to talk, okay? He is a neuro-oncologist, an early drug development specialist at MSK in New York. I looked at his resume and you incredible work you are doing, incredible accomplishments, and your research and your publications from that research are vast. And I just want to say thank you to you because
thanks.
Truly, you really have dedicated your life to research and to this disease as well. So thank you. His areas of expertise are primary brain tumors, CNS lymphoma, central nervous system lymphoma, and brain metastases. We are so delighted to have you today, Dr. Grommes. We need more people, special people like you. Thank you. I also want to thank Curis Therapeutics for bringing us together, for investing in the disease of PCNSL and into this research, and for helping you and I and the End Brain Cancer Initiative with this educational video for patients and the PCNSL community and the distribution, which will be global, helping us with this project. So thank you, Curis Therapeutics. We're going to head into our session number 2, which is more in-depth treatment options. You talked about something that was very interesting, that within PCNSL disease, I think I heard you say, there really is not a standard of care. So my question might sound a little strange, but here it is. Standard regimens. I think we are talking about standard treatment protocols and their side effects.
Well, standard of care is defined as everyone uses it because everyone we have data that shows that is the best treatment at this moment. Well, what we don't have is a lot of phase 3 comparison trials in PCNSL. What we do all have is phase 2s, larger phase 2s, a few phase 3s, and ultimately what we can argue, or what we all in the field agree, is that it needs to be chemotherapy, and the chemotherapy should include methotrexate. And so that is the first step. That's what we like to do, and we combine it with other agents. Now, methotrexate is also, unfortunately, the most potentially side effect ridden agent because it can cause renal failure. And so you have to be very careful by giving it. The patient needs to be generally admitted, gets a lot of hydration, and we have to make sure that the methotrexate is cleared out of each patient's body before they can go home. We treat patients every 2 to 3 weeks with methotrexate, depending on the regimen that you use, to avoid also effects on the bone marrow from the methotrexate and other agents. And that is, I think, what we all, as a minimum, agree on. And then the methotrexate is come out with other agents, again, depending on your experience and the patient, as well as your training.
So how long is a typical treatment last?
Yeah, so we like to use 8 doses of methotrexate every 2 weeks. So 16 weeks generally is the phase with the methotrexate, which then is generally followed by something we call consolidation, meaning we like to switch chemotherapies to make sure that there's no early recurrence by giving some additional treatment.
And then if you say you admit the patient for a treatment, right?
Yeah, we do.
And then you make sure that it is cleared from their body before they get to go home. Is there a kind of a typical time period for receiving like one treatment? Like, does it last like 4 hours? I don't know.
Oh, I see. No. So, so you come to the hospital, you get your hydration, you get your chemotherapy, which is generally methotrexate is infused within like 2 hours, and then continued hydration. And then every day we check the level of methotrexate, and if it's under a particular threshold, patients can go home. Again, we're very concerned about the effects of methotrexate on the kidneys, also on the bone marrow, but mainly the kidneys. There are some institutions that do give methotrexate now in the outpatient setting in a very highly selected patient population, because you have to really make sure that they hydrate well and that there's close follow-up. But this is a disease in the elderly patient population, and there might not be a lot of functionality. You need a lot of family support if you do this in the outpatient setting. We also have, investigating some new approaches on how to deliver methotrexate in the outpatient setting. In every patient, there's obviously more going on to make this better and easier for our patients, because who wants to be admitted every 2 weeks for 3 to 5 days? It's also taxing for some of our patients. And so, that's generally.
Okay, so that admittance is from 3 to 5 days.
Yep.
I did not understand that. That's good to know.
Yeah.
That's good to know. And so you did mention that healthcare providers pay very special attention to the levels of this drug in their kidneys or anything else. I assume there's quite a bit of blood work done. And did you say you check it it's checked every day that they're within the hospital?
Yep. And if they're in the hospital and the level is too high, then we have to be a little bit more intense. We intensify our ways of protecting the body from methotrexate and getting the methotrexate out. I have seen it both ways. On the one hand, there are families that say the whole every 2 week being admitted is taxing. And we have seen patients that are part of our trials to use it as an outpatient. Say, that back and forth is not that easy. I want to be admitted so I can focus on being in the hospital, clearing the methotrexate, and can go home. So it really is not a straightforward path, and I think it depends on the preference of the patient, the family situation, but the location. Manhattan doesn't have a lot of parking spots, so getting back and forth here is a little bit more difficult. Is really the more intense part of this treatment.
Thank you. Is there anything else a patient could expect with treatment?
Well, yeah, each of the drugs that we combine with methotrexate has its own side effect profile. In general, what we try to avoid is count drops, the white count drop, or the platelet drops, or the red count drops. So we give supporting medication. Some of the medications, for example, vincristine that we sometimes give with methotrexate can cause neuropathies, so we have to look out for that. Nausea can happen with just doses for that, liver enzyme elevation. So me personally, I like to start with all agents and peel off agents depending on the side effect profile, rather than start timid and add things. Especially in a disease that is chemosensitive. This is not like a glioma. You want to be upfront, you want to be aggressive, and you want to give the patient as much chemotherapy as possible. And if you have to peel off, that is, I think, the better approach than adding on, because you might never get to it because of side effects up front. But I think there are treatment differences depending on where you get your treatment, but it's generally all of the time based on methotrexate. It gets a little bit more challenging if you have difficulties with your with your kidney, and you have chronic kidney failure, or you have a kidney transplant already to give patients methotrexate. Then it gets a little bit more tricky. And I would then recommend really to go to one of those special centers, because they have a little bit more experience with giving it to patients with maybe only one kidney or after kidney transplant. And that is actually a very common scenario that I see patients that have developed kidney problems with 1 or 2 treatments of methotrexate, and then what to do now. And so that's actually something that happens very commonly.
Okay, thank you for that information. The next question is about outcomes and rates of, I use the word remission and you use the word refractory, right? So what would you say about that?
The question about outcomes is always how you define outcomes. So first, is there a response? That means with the means of detecting the tumor, do we see it shrinking? So you can have a partial response, a complete response, stable disease, or none. None of that, and that is progression. And so the next step then is, if you have no response to therapy, then that is called refractory. What you also can see is there's an initial response and then it bounces back immediately, and that is also refractory. That is actually methotrexate refractory disease, which is extremely difficult to then treat. And so, but in general, well, let me say, it's about 15 to 20% of patients that are refractory to methotrexate. And that is, again, difficult to treat population, but about 80% of patients respond to methotrexate and then receive a consolidation if they can, if they're able to tolerate that. Then we're saying, okay, the imaging doesn't show anything, so we are in remission. Now, in other cancers, in other lymphomas, if there's a particular time frame that is passed and you're in remission, then you're cured. More primary CNS lymphoma can recur after 5, 10, even 15 years. So even though I would love to say you're cured, I can't really say that because it's a possibility of late recurrences. So I usually like to mention to patient that they're in remission. But so the remission rates at 2 years usually are around 60%, a little bit better, worse, depending on your age group and your comorbidities again. But that is, again, mostly in specialized centers. Outside of specialized centers, it might be a little less. But again, that really depends.
Thank you. Thank you. So if I'm a patient or I'm a care partner and my loved one is going through treatment, what would I look for that would be harmful, right? Like what am I looking for that would make me go, wow, we need to go to the ER. We certainly need to let our physician know what is happening. What types of things would we be looking for?
Yeah, clinically, not that much, actually. We would be very concerned if a patient doesn't get better neurologically, because that means, the chemotherapy is not working and that's a refractory patient. Or if patient get better and then worse again. But that's another thing. The neurologic exam or the neurologic presentation is really helpful in our patients. Now, we do regular blood counts on these patients in the hospital, outside the hospital. So we know when their platelets, for example, are low. So we are not really seeing surprising admissions because there's a hemorrhage in their brain because of a low platelet count, because we monitor these patients very closely. Yeah, I usually say to my patients, if there's any change in their neurologic presentation, even if they're concerned about small changes, they can just always get in touch with the team and me, and we determine very quickly what happens. The good thing about these patients is every 2 weeks, they're also in the hospital. So we really have a close understanding of their clinical journey and their counts. And so it's rarely that these patients slip through and develop a symptom that we don't see coming.
It's quite honestly quite wonderful that these patients are, I'm using the word monitored so closely and often. You don't always see that in other diseases, in other cancers either. And so that is fantastic.
Well, we do treat also these patients with a lot of chemotherapy. So we do have to monitor them closely because they can develop thrombocytopenias, also low counts of their platelets, low counts of their white count, and that sets them up for potential bleeding risks or potentially infections when the white count is low. And that is obviously different than what we do with gliomas, where we do radiation and temozolomide chemotherapy, and it's not as intense. And unfortunately, I also, if I share, had once a family where one person had a glioblastoma and the other one had a lymphoma in different times. And the glioblastoma patients, unfortunately, noticed, why am I not treated as intense than my family member that had a primary CNS lymphoma. And that is just because the intensive chemotherapy doesn't work as well in glioblastomas. So that's why we don't actually do that. And so that's sometimes a very stark difference. And that's why also we don't do the controls or the supervising and the lab values in glioma patients that frequently, even though we do look at them every week too.
Yeah, thank you so much for explaining that. That's very helpful information. We'll wrap that section up, which was treatment options.